Hello everyone, and welcome to CK Med. My name is Clark, and I'll be taking you through the second part of upper limb today. To start things off, last time we discussed all our basic anatomy of our upper limb, and now today we're going to be covering more of our clinical aspects. There will be additional anatomy that we're going to be kind of pointing out right now. However, it's mainly going to be focused on your clinical presentation, in addition to some physical exam findings that I'm going to be talking to you today that kind of come into play that you'll be learning in year 2 of medical school. So to start things off, we're talking about our rotator cuff muscles. And our rotator cuff muscles are important muscles that maintain the shoulder joint in the shoulder joint. All these muscles kind of rotate and move this shoulder joint, not only keeping it in its place, but rotating it in different directions for allowing for full mobility of your upper limb. Now, we discussed last time some of our muscles, such as our serratus anterior, which help with our scapula, which moves the whole unit of their scapular humeral area for allowing for our arms to be moved out and ability for them to be lifted up over the head with the use of our trapezius, supraspinatus muscles, and our deltoid muscles. But for this one, our rotator cuff muscles are made of 4 sections of muscle insertions that allow for different rotations as well as abduction of the humerus. And so these muscles actually spell out this mnemonic SITS, which is written down here. I really hate this mnemonic, but it's just way of one putting it. And so when we're talking about this, the muscles we're discussing are our supraspinatus, our infraspinatus, our teres minor muscle, not our major, our minor muscle, and our subscapularis. Our teres major is a different muscle, but is not a rotator cuff muscle. It's helpful for attachment on the humerus, kind of lower down here. Remember, our minors above our majors, so the major is going to attach way down here, but it's not around the rotator cuff, so the minor is on top. Higher up means higher around the humerus, therefore we can actually consider the minor part of our rotator cuffs. So all these muscles have different functions and very highly testable on your BSc1 and BSc2, as well as your CBSEs, your NBME practice exams, and your Step 1. I can ask you a lot of questions about each one of these muscles. Simply someone saying they have shoulder pain and then they cannot do this certain movement. It's only 4 muscles you have to learn and learn how they function. And so our supraspinatus came up when we were discussing lifting our arm over our head, but it initiates the 0 to 15 degrees. And so if you were to move your arm from 0 to 15 degrees, the only muscle that is engaged is the supraspinatus. That's why we consider this as the muscle that contracts and moves it from 0 to 15 degrees. Once we get above 15 degrees, it does not mean the supraspinatus turns off and does not contract. It stays contracted, but from 0 to 15, it is the only muscle that does this. So let me show you this kind of arc here. So if I have the arm down this direction, and then I go from 0 to 15, this is supraspinatus, okay? That does this degrees right here. However, if we go from this up to about 110 degrees, 110, this is going to be your supraspinatus did the first to 15, and it stays kind of contracted, and then the deltoid does the rest of this. So if I were to say someone has their arm out at 110 degrees or even just 90 degrees, what muscle allows for this to occur? Well, that would be a trick question, because I can't ask you that question, because it was both supraspinatus and deltoid that got us up to that. They added together to get us up to 90 degrees or 110 degrees abduction. And so the real question I would have to ask you is, what muscle allowed for our arm to be abducted up to this 110 degrees from where our supraspinatus was allowing our arm to be abducted to? And that means this particular aspect. What allowed us to go from this point to this point, that is our deltoid muscle. And so what I can do at this height is imagine and take your arm out, extend it, or I'm sorry, flex your arm out in front of you. If if you have your arm flexed out in front of you as if you were reaching out to grab something on the shelf in front of your face. Okay, you have your arm out in front of you. Okay, and if you turn and internally rotate your whole arm, so your hand is pretty much like upside down, as if you're pouring out a can of soda. So this is called your empty can. What this does is, at this position, your arm is up at 90 degrees, but at the same time, you've now internally rotated, turning off your deltoids aspect of this. And so if you had a particular muscle known as your supraspinatus damage, this test would be very painful for you, because when you internally rotate or do this empty can test, the supraspinatus is pretty much the only one that's allowing your arm to stay up there. It's the only one that gets taut, because we kind of turn off our deltoid muscle at that particular position, or its particular field of contraction doesn't work very well when you're doing an empty can sign. And so if you had a tear of your supraspinatus, that's what you do. You have their arm totally flexed in front of them, 90-degree angle in front of their face as if they're reaching out, and do an empty can. And if you push down on that, or even just when they flip their hand over, it hurts. That's the sign of a supraspinatus tear. So I'm going to write this over here, empty can test. And that is a particular physical exam you'll learn better in term 2 and actually learn how to do that. But you can do that right now on your friends if you want. Maybe tear their supraspinatus and have them do this, and you go, I can see that this is a positive test. Okay, don't do that. That's terrible. All right, so that covers our supraspinatus. Next are our less important ones. Obviously, all of them are important for your rotator cuff, but less likely to be tested, but they still show up on your BSE, so keep this in mind. Your infraspinatus, which is right here, so we have our supraspinatus, and then we have our spine, and then the muscle that's below this would be, I wonder, would it be subspinatus or infraspinatus? Well, that's our infraspinatus. And so what this muscle does, it reaches right around here, and if it contracts and grabs on to here, it's going to yank on the outer portion of our humeral head. That allows for lateral rotation, which makes sense if you look at its insertion site. That's pretty much the important thing there. Both of these muscles are controlled by your suprascapular nerve. That's not that important, but just so you know. Your teres minor muscle, another muscle down here, again major down here, attaching in on the humerus, where your teres minor is above that, and that's going to be part of our rotator cuff, and that's going to be our lateral rotation of the arm, where teres minor actually attaches and does teres major is the one that does medial rotation. Teres minor is lateral rotation, teres major is medial rotation. Okay, big M for big M, medial. Next is our subscapularis. So this is actually on the other side of our scapula, under it, and so this is one that people like to tear a lot, or get kind of pain under their scapula, and then someone goes to massage them and they can't find the tender spot until you push down on their entire shoulder blade, and then that goes, ow. That's where this muscle is found. It's under. It's sort of like the clam under the shell. It's this hiding muscle under the scapula, between your chest wall and the scapula, and that's this muscle right here. It's on the more anterior side of your arm, and so if it reaches around the anterior side of your humeral head and contracts, you can see that this does your medial rotation of your arm. And those are all your rotator cuff muscles. Okay, so next, since we're at the shoulder, we're going to be discussing some of the things like shoulder dislocation. Now, shoulder dislocation is a problem because it can impinge neurovascular structures, cause a whole bunch of problems, and then you also have to know, okay, at what one point in time do I see this in an image, in an x-ray, so be able to point that out, that that's a dislocation. The second thing is what can be damaged, and the third is how it can present in symptom-wise, or where this patient is going to have a lot of pain. In addition, at what kind of clinical scenario do you get a dislocation? And so with shoulder dislocations, we can see this x-ray up here, and I know this is an x-ray because It looks like an x-ray. We have white bones and we have black everything else, air and lung tissue and air outside. And then fat and stuff is kind of in between. That tells me it's an x-ray. This is a shoulder x-ray, and I can see my clavicle right up here. I can see my acromion, I can see my coracoid process, and then my glenoid fossa comes right down here. And then here's the humeral head. Well, this humeral head is supposed to be right here, and so you can see that this is a dislocation of the humeral head. I don't see any fractures necessarily, but I do see that it's a dislocation. And the most common place that you actually find this is anterior inferior. Anterior inferior is the most common place that you're going to see this. And you might think, okay, why would I see an anterior inferior dislocation more commonly than anywhere else? It's because more people get this dislocation because of high fives. So I put this little Seinfeld episode, the high five, and I love this one. It's really funny. But what happens, imagine if you put your arm up, or you're jumping for a basketball, or you're going to block someone in volleyball, or something goes up when your hand is raised in this position, and I do excessive force smacking that arm or that hand or that whole entire shoulder or something like that down this way. Here's my humerus. If it's in a line, and I put force here, the force in the shoulder is actually going to go anterior and inferior, because I'm going to be going kind of down on this. So this is the classic high five presentation, or someone landing on someone's arm that's trying to block them in basketball, and that causes an anterior dislocation. And that's why this occurs more commonly, because that's where we actually find this. Now, the damage that actually occurs as far as the ligaments is going to be your acromioclavicular. So acromioclavicular makes sense as to where its position is, because you have your acromion and you have your clavicle, and so acromioclavicular is the ligament found right here. So you often see this kind of separation between these. This picture doesn't actually show it, but if it did, you'd see a separation between the head of the clavicle and the edge of the acromial process because of that ligament. That's less likely that you get a question on this particular ligament unless you see that in a picture. But if you have just a clinical vignette saying someone was playing basketball, someone landed on their arm as they were trying to block, and now they have shoulder pain, their arm looks like it's out of the socket, what is the nerve or artery that's involved here? Well, you have to think of what's in this surrounding area. Well, we have nervous structures that come down here, and that's part of our brachial plexus. And our brachial plexus gives off all these different branches that go to different areas, and we've discussed that in our last video. But here, one of them that's very important is our axillary nerve. Our axillary nerve comes down, sneaks under the arm, and then switches up here to break off its nice branches up for the deltoid. That's the most important thing that this does. However, since it lies right under the humerus, if this goes downwards and anterior, we're going to kind of shred that nerve, and so our axillary nerve is going to be a problem. So what is this clinical presentation? I have a 25-year-old man playing basketball. He jumped up to block a thing, and now his shoulder hurts, and he's unable to abduct his arm from 15 to 90 degrees. What nerve has been damaged? Well, it already tells you 15 to 90 degrees, which is your deltoid muscle. Your deltoid muscle is controlled from your axillary nerve, and therefore your axillary nerve is damaged, and it makes sense because it's located in this area. And then following that, you also have to think of what is the blood supply that's surrounding the neck of the humerus, and we've already discussed this. There are the last two branches of your axillary artery are your anterior and posterior humeral circumflex, and the one that does get damaged most commonly is going to be your posterior humeral circumflex. And it all makes sense because they're all located right there, and if you have the humerus sliding down, it's going to shred some things that have the nerve that run under there and the artery that runs right under there as well. Okay, so next is our thoracic outlet syndrome. And this one kind of does come up a lot in our BSE and NBME exams. So I want you to get this extra point come that time, because you're going to remember this video on this slide in this particular section. Okay, maybe not, but at least this is a point where you can learn this and never forget about it. So you can get those questions correct come BSE. So thoracic outlet syndrome is a particular condition that has weird things that occur. And so usually our cervical vertebrae and our thoracic vertebrae are separated because that dividing line shows that there's ribs below in our thoracic, versus no ribs in our cervical or our neck. This is the usual presentation, is that there's no ribs at the cervical and ribs at the thoracic. But sometimes we have an extra rib that grows off of the cervical region and wraps around. And so we have this kind of heightening of all our structures, our blood vessels, which are veins and our arteries, and our nerves, which is the brachial plexus that runs right over these things. So if I have this extra rib right down here, then this can be a problem because it can impinge these certain structures. In addition, we also have muscles that run along on top of these ribs that also can constrict these blood vessels and our nerves here. And so some things that we find, if the vasculature is involved, such as squeezing in on the artery, then we're going to have what is called a bruit. And our bruit is a rushing sound through an arteriole that you hear. It's almost like a sound that runs right through the artery when it's sort of mechanically occluded or like halfway closed. And so you have this turbulent flow, and you can hear that on stethoscope. And so imagine this scenario. I have a 45-year-old man that has had 20 years of intermittent upper arm pain. He's noticed it mainly when he's working out and lifting things up over his head, such as his shoulder press in the gym, or he's doing some lat pull downs where his arms are up over his head. He gets weakness when he does this, and then he puts his arms back down, and eventually it's fine. Now, if I do a physical exam and I listen to his shoulder, I hear a bruit. This automatically tells me one of two things. Either it's thoracic outlet syndrome because he has an extra rib, or two, he has a large cardiovascular risk. Like the stem is going to be describing him having atherosclerosis, has high cholesterol, he's been smoking for years, and he has angina or ischemic heart disease. All those things put together, that it's more of an atherosclerotic plaque that is occluding this vessel, like a plaque here, so the blood has turbulent flow, versus someone that actually has a mechanical obstruction due to a rib. So those are two things. If the stem tells you all these different cardiovascular, then that's atherosclerosis, versus if it's not that, then it's probably an aberrant or extra rib that is causing thoracic outlet syndrome. And you might ask, okay, well, that's the artery. What about the nerve? Well, the nerve describes tingling in the hand sensation, mainly on your medial aspect of your pinkies or in your inner hand, and the medial aspect of your forearm as well. This is pretty much telling you ulnar or lower trunk or lower brachial plexus kind of obstruction or damage or impingement that's occurring when this person has their arms over their head. And so what do? How do I test this? Well, what I do is I have them lift up their hand and squeeze their hands together for a couple minutes. And eventually they start having painful symptoms in their arms, numbness, tingling, or even weakness. And that's a classic physical exam I can do by having their arms out at like 90 degrees or even up over their head, and they have those symptoms. And that is thoracic outlet syndrome. Now, as to the reason why embryologically you have this extra rib, comes down to some of your Hox genes. And so your Hox genes are very important for separating the different cervical spines, different parts of our body, and locating them where they're supposed to be. Instead of having an arm come out of your neck or an arm come out of your hip, you have a Hox gene that says your arm should come out of your shoulders instead. And so all these Hox genes kind of align everything, and you can see this like, oh, this is supposed to be our cervical region, this is supposed to be our thoracic region, this is supposed to be our lumbar region, and this is supposed to be our sacral region, defined by these, random colors that they use here. And so all these genes are expressing the appropriate respective areas here to kind of lay down the framework of where the body parts are supposed to be growing, and those are our Hox genes. However, if one of these gets misaligned and it starts expressing things from one section in another section, such as the ribs of the thoracic region, maybe the genes for the ribs start expressing up here in the cervical region. Well, what are you going to have? You're going to have ribs that come off of your cervical region. And that's exactly what we were just talking about with thoracic outlet syndrome. So your Hox genes are important for doing this. And it pretty much comes down to Hox genes expression more rostrally to its normal presentation in the thoracic region, which just says genes in your cervical region that are supposed to only be expressed in your thoracic region to make ribs are now being expressed up in the neck, and so you get ribs growing there. Okay, next are less important things, but I must teach you them because they do come up, is your different spaces and intervals around your shoulder. And there's 3 of them that you should know. The first is your triangular space, the second is your quadrangular space, and the third is your triangular interval. And so all these things kind of have particular things within them that are found and important that you should know. And so your triangular space, which is the nice blue guy right up here. So your triangular space is the blue one right here. This is the thing that houses your circumflex scapular artery. We talked about this for axillary anastomosis and our scapulary anastomosis. That's that artery that circles around off of your axillary artery. Next, we have our quadrangular space, which is the one that makes the 4 thing. That's why we call it quadrangular space. And that houses your posterior humeral circumflex and your axillary nerve. So I can imagine if someone gets stabbed in the back of their shoulder in the quadrangular space, that this might come up as a question as to why does this person have decreased deltoid muscle contraction. So what did we say? 15 to 90 degrees has problem abducting their arm. In addition, you have that posterior humeral circumflex damage. And then the triangular interval, which is this green one down here. This houses your deep brachial and our radial nerve. And so this is a nice other presentation. Someone gets stabbed in the back of their arm lower than the quadrangular space between the tricep muscles. If it says between the tricep muscles, then you'd be thinking of the deep brachial artery as being damaged, or if it talks about nerve deficits in your radial, such as extension of the forearm and extension of the wrist, that is a radial nerve damage. Why? Because this guy got stabbed in the back of the arm in the triangular interval, and that damaged his radial nerve. Okay, next are some of the fractures and epicondylitis of the arm. And this is going to be kind of very nicely sectioned off for you. And this is one of the easiest ways to remember pretty much what nerve is damaged in certain areas. And so if I were to take the humerus, I have the head of the humerus, I have the neck of the humerus, I have the shaft, and then I have the supracondylar, and then I have my condyles, my medial and lateral epicondyles here. And this is where my olecranon kind of hides in here, or my elbow, or my funny bone, as if you can call it. And so if I have damage all the way up at the surgical neck, which is right here, the surgical neck is an important thing that if I damage, I'm going to have damage to my axillary nerve. The posterior humeral, again, circles around this way. So if I have damage here, it makes sense that the posterior humeral artery, but axillary is really where all the questions come down to. And so that is going to be my A of my supracondylar at the top. If I have a mid-shaft fracture, so right down here in the shaft, I'm going to be damaging the blood supply that comes deep, runs right along here, and then ends here, which is my profunda, or deep brachial artery. As far as nerves that come important here, there's a nerve that spirals right around this nice radial groove right here, and that's your radial nerve. So the nerve that's damaged here is my R for radial nerve. And then what we have is our supracondylar fracture. We'll come back to this one in a second. Supracondylar fracture. This one is right down here. And if this fragment kind of goes anteriorly, we're going to damage a nerve known as your median nerve. And so that's my M. And as you can see, these are the 3 sections of the humerus that are fractured. And so it spells out arm. Wow, doesn't that totally make sense? Okay. And then one particular thing, we have another nerve that runs along here, and it goes right past this little hump. And this is known as your medial epicondyle. Medial epicondyle. Okay? If you have damage or fracture of the medial epicondyle, that nerve that passes there is your ulnar nerve. And so this one is my U. Okay, so those are the 4 nerves that are damaged when you have a humeral fracture. Next is there's attachment sites to these areas, and those on your radial and on your radius as well, and your ulna. But these attachments are either your extensor or your flexor compartment. So if you look at your forearm right now and you do a action of extension of your arm, and you grab onto your medial and lateral epicondyles, like where the muscles are inserting, and you do a kind of a extension of your wrist, as if you're going to do a backhand swing with tennis, a backhand swing. Well, where do you feel that contraction inserting? Well, that contraction inserting is on the lateral side. So your lateral epicondyle is the place where all your extensor muscles are attaching into that point, and that's why when you're doing a backhand of tennis, you get, and that flicking of the wrist in the extension, posteriorly, that is why you get lateral epicondylitis as called tennis elbow. And so tennis elbow is a lateral epicondyle. So you can see this right here. So if we're looking at the arm here, we're looking at the back of the arm, by the way. So this is the back of the arm. So, no, this is someone's left arm. So the flexors are here, and then your extensors kind of circle around, go back all the way this way, and come down this way. And so when you're flicking the wrist, that goes backwards, this way. That allows for attachment of all these. Lateral epicondyle has all your extensors, and that's why you call it tennis elbow. Where if you're going to swing a golf club and just using your right hand, how would you flick it? You would actually flex your wrist. Flex your wrist with that golf club to hit that thing really far. And that's why if you feel when you're doing a flexion of your wrist, where's the attachment of those muscles? That is actually going to be on your medial epicondyle. And that is why we call Culfer's elbow medial epicondylitis. Okay. Next is an important thing that does come up even more high yield than anything that we've discussed so far is the anatomical snuffbox. And so the anatomical snuffbox has a few different things that are important. One, it houses the last sensory nerves of your radial artery, your radial nerve. And your radial nerve just does sensory on the back of the thumb and pretty much the back of the first few digits here. That's your radial nerve sensory areas down here. It doesn't innervate any motor at all down here in the hand, but it does do sensory. And then it also houses the last part of your radial artery. So your radial artery, usually we feel it when we're feeling the pulses right here in your forearm in this area, right? This is where we usually palpate this. However, we can also palpate where it ends, which is actually up in the anatomical snuffbox. The anatomical snuffbox is right here, and those are the two things that kind of run in there, the radial nerve and the radial artery. But the floor of this anatomical snuffbox, the very bottom of it, is a bone called your scaphoid. And we're going to be discussing this when we get to the carpal bones, but the scaphoid bone is the most commonly fractured carpal bone in the wrist. So someone falls from, ground level fall, they have their hands stretched out in front of them, and then they hit their wrist, and it hurts really bad. And if you push in this anatomical snuffbox, which is just on the lateral or on the posterior aspect of your wrist, near the back of your thumb, around your abductor pollicis longus and extensor pollicis longus, and your extensor pollicis brevis, make this housing of this anatomical snuffbox. If I push on this and it elicits pain, it's your scaphoid bone that most likely is fractured. Next is our nursemaid's elbow. Nursemaid's elbow is a dislocation of your annular ligament. This usually occurs in children because the annular ligament is very squishy and weak, where it gets stronger as you get older. And so this is why they call it the nursemaid's elbow. Imagine you holding onto your kid's arm, only one hand, and you're about to step into the middle of the street, but a car comes racing up. And so you go to grab your kid and lift them up by one of their arms, just like this hand is doing to this child right here that apparently is not wearing any clothes. But when we yank this, it pulls the radial head, which is right here, out of this annular ligament, and this is called a radial humerus dislocation, and that the ligament that is involved is your annular ligament. Now, as far as treatment for this, you can wait to learn that in year 2. Musculocutaneous nerve. So this is now we're going to be getting into each of our nerve sections as far as pathology. When you damage these nerves, what are you going to lose? In addition, what's their innervation? And then is there any sensory that comes along with this? Also, if the pathology has a name, we'll point that out as well. And so each of the brachial plexus has a nice section of damaging to the nerve and what's happening. So before we talked about this, with our brachial plexus that comes down, if we pick out each individual one of those 5 nerves, they all start off with kind of this motor innervation first, and then once we get off all our motor fibers, we finish off with our sensory. So our musculocutaneous, starting here on the medial side, travels in this direction out to the lateral side. And so we'd give off once we pierce these muscles and go into this compartment, this is where motor ends, and then it continues as sensory on the lateral part of the forearm. And that's actually all you need to know, is what does it innervate basically here? What's the muscle it breaks through, giving motor to this compartment for flexion of the forearm, right? This is your biceps muscle and your coracobrachialis muscle and your brachialis muscle. All these guys flex your forearm. Those are your biceps. You know, the big muscular guys flex to impress girls or something like that, right? But then it continues down to do sensation on the lateral forearm. I couldn't tell you how high yield this particular nerve is for no apparent reason, but it is on your BSCEs and your step 1. Someone just comes in, they have damage in their shoulder for some reason, dislocation, something's going on that hurts their shoulder and the nerves involved, and now they can't flex their forearm and they have decreased sensation on the lateral forearm. Bam, musculocutaneous. Like, you now have gotten the question, move on to the next one. As far as the specific muscle, because this one does come up in questions as well, like a 100% anatomy question, is coracobrachialis. So I just remember that this nerve, your musculocutaneous, cracks through the coracobrachialis. So if you ever get this question, you're probably going to get it in lab as well when you go and meet with the doctor. They're going to go, hey, look at this muscle right here, and I see a nerve piercing and cracking through it in the forearm, or in the flexor compartment of the upper limb on the arm. What's going on here, and what is this muscle and what is this nerve? And you go, oh, well, that I can remember. My musculocutaneous is the one that coracos through the coracobrachialis. And then you're going to get that nice point there. Next is, once it continues down for your sensory, the actual forearm is the lateral cutaneous nerve of the forearm, which actually just 100% describes where it's going, so you can't get that one confused very well. Next, as far as if you lesion this, musculocutaneous can be damaged in things like upper brachial plexus lesions with Erbs Palsy. Erbs Palsy is its own kind of syndrome. We'll be talking about that, but that's something that can damage this nerve and have those findings. Okay, so since we're talking about those brachial plexus lesions in the upper and lower, let's talk about the names. So we just talked about Erbs. Well, so what is Erbs? So Erbs palsy is something where we have a wide separation of the shoulder and neck. So just like this guy falling down, and he's got this nice kind of large open angle between the shoulder and the neck, that is going to separate and rip the top of the brachial plexus. So if I draw this like this, here's the neck, and then here's the shoulders of this nice happy guy right here. Okay, the brachial plexus runs just like this. Here's all the things, so 4, 5, and then we have our little crossings and things. Now it looks like a strange brachial plexus. All right, if I increase the angle in this and stretch it out, I'm going to stretch this upper part first, and that's how I get a upper brachial plexus lesion. Where instead, if I have someone that yanks this arm up this way and stretches out the angle here, instead on the bottom, I'm going to shred the bottom part of this, and this is called Klumpke's palsy. And so when I have a separation of the shoulder and the neck, this is going to tear the upper brachial plexus, and this leads us to have Erbs Duchenne's palsy, also known as waiter's tip position. And you can see this shown with this baby up here. So what happens, the nerves that are damaged obviously are C5, 6, and sometimes 7. And this is waiter Sam. And so this is our 3 nerves that are are three areas that are messed up here. The nerves involved. So that's your musculocutaneous, and your axillary, and your, well, I mean, not part of the main nerve here, but your suprascapular nerve as well. But the ones that are really involved in what you actually see is this person cannot flex because we've lost our musculocutaneous, so the arm is straight. It cannot flex the forearm, or it cannot extend the forearm. And so that's going to be important for part of our radial nerve fibers, but particular some of our superficial fibers. And then we have this Waders tip, which is C7. And so all these nerves, if you just think of what the three were there, so we have our three musculocutaneous branches, C5, 6, and 7 make up musculocutaneous. In addition, 5, 6, and 7 are important for our radial and our axillary nerves that come into play as well. But what really just happens, be able to recognize this presentation of someone falling like this guy up here from a building onto his head and his shoulders, and it hyper lateralizes his head, and then he has his whole arm is straight and his hand is flexed up backwards. This is Waders tip. That is Erbs Duchenne's, also known as upper brachial plexus lesion. And then for lower one, it's wide separation of the shoulder and body. So that's like someone falling from the building and trying to grab branches as they're falling down through the tree outside their, skyscraper or something. Yes, that's exactly how the questions are written. So when you see that, you're going to know what's going on here. In addition, you can also see it in OB procedures when you yank the baby by the arm. This can damage this lower part of the brachial plexus as well. And you can also see this presentation like we discussed with our thoracic outlet syndrome, because you have the nerves kind of, instead of the nerves brachial plexus coming out like this, right? With the cross and stuff like this is the brachial plexus, and then we have the rib down here. Now we have the rib higher up here, and so now we got to lift this brachial plexus up and over, and so it's going to compress this lower part of brachial plexus. And so thoracic outlet syndrome can lead to Erbs palsies as well. And then the nerves that involve are median ulnar nerve, and that's your C8T1, the last part of your there. Things you'll see are a lot of the ulnar and median nerve involvement. So median nerve is important for flexion, and ulnar nerves are important for flexion of the wrist. So this person is going to have a hyperextended wrist. In addition, ulnar nerve is important for pretty much all your intrinsic hand muscles, median nerve, all the remaining ones. And so this hand is going to be really flaccid and dead, and they're going to have a lot of atrophy in that hand. And so it's a flat, like ape hand. If you just Google what an ape hand looks like, you'll see how flat and kind of funky it looks. And that's that way. So let's describe some of the median nerve once we get into the forearm. We've talked about it, where it comes off, what it's made of, C5 through T1, pretty much all of the fibers make up those. And so the median nerve, what it does, I'm not going to describe every one of these branches. That's ridiculous, because you don't need to really know that. But you do need to know kind of where basic lesions can occur. And so as the median nerve comes down, it doesn't innervate anything in the arm, but it does in the forearm. And the median nerve does a couple things. First, it gives off what I was saying as the general concept with nerves is going to be your motor first. And so the motor dives down into our deep branches, which is going to be this entire branch right here. And this is going to be innervating your flexor digitorum profundus and superficialis and flexor pollicis longus. All these things kind of come off of these motor branches. Yes, there's a deep one here, but it does come off of these little branches you can see off of the side. So it innervates all this motor stuff first, and this allows for flexion of your wrist. That's what these do. So we have our muscle that runs right here and allows for contraction of the wrist to flex it. So if I have a damage to the median nerve all the way up here, before the motor gives off and before the sensory, I'm going to lose everything all the way down. And so how do I have a damage to the median nerve? Well, we already talked about that. That is a supracondylar fracture of the humerus. That damages my median nerve. Or if I have someone that gets stabbed in their antecubital fossa and it damages a nerve, well, that's the median nerve that runs right over that. And so you can lose it right up here. So we lose all motor and then following sensory down here. The motor it also does is continues down into the hand to control some of the motor muscles associated with your thumb and the first few digits. And these are actually your loaf muscles, L-L-O-A-F. And so the first two lumbricals, 1 and 2 lumbricals, those are important for the bye-bye muscles of your first two fingers. And then we also have our opponens pollicis. So this allows for opposition of your thumb to touch your pinky finger, kind of to make a nice loop in between them of your hand. So opponens. And then we have our abductor pollicis. So your abductor pollicis brevis, that allows for this to be kind of abducted, your thumb. And then we also have our flexor pollicis as well. And so that's very important. It's abductor, not adductor. Adductor is controlled from your ulnar nerve. So abductor is important to know. But all of these are the muscles that your median nerve does in your hand, and all the rest of them, all the remaining of your lumbricals, all your intrinsic muscles of your hand, in addition to your adductor, which is the muscle that found right here, to bring your thumb back in this way. And so what happens if I damage just all the way up here, I'm going to lose everything as far as the loafs in your hand. I'm going to lose sensory of the median nerve, which is pretty much all of this. This is all the sensory of your median nerve on your palmar surface. Your ulnar nerve does this, the second half of that thumb, and this does sensory, and that's ulnar nerve. Okay, so if I damage my median nerve up here, I lose all the motor in the forearm, so I can't flex my wrist, I can't do anything with my thumbs, I can't do bye-bye with my first two fingers, and then I also lose sensory of your lateral three and a half digits. And over your thenar eminence, or your eminence right here, thenar eminence. That pretty much tells me I have a median nerve damage all the way up high. But instead, if I just go further down, say at the wrist, I damage the median nerve, I'm going to lose my loafs, and I'm going to lose my sensory of my hand, but I can still flex my wrist because these motor branches are totally intact. And that's an important thing to know. And then we also have damage in the hand, specifically just at the thumb, is this recurrent branch. And so that's this one right here, this recurrent branch. If I damage this nerve, meaning I got stabbed in my hand, then I'm just going to lose OAF. OAF. That's all I'm going to lose of those. That's the OAF is the one that's controlled from recurrent branch of your median nerve. And that's actually a super high yield point. So definitely high yield, and we'll emphasize that in just a second again. So here's the median nerve lesions. This is the nice description of my wonderful drawing on the last picture. Here's the sensation that it does on the palmar surface of your hand. It also controls all your motor here and your motor of the first two lumbricals found here. And then it does a little bit on the back side of these last couple fingers here. And this describes each of the sections. So if I have at the elbow, I'm going to lose everything that median nerve does, pretty much. If I lose it at the wrist, then it's just the lobe muscles. And if I just have that proximal or palm recurrent branch of the median nerve, then I'm going to lose my OAF muscles. And this is not double L. I need to cross that off. Just my OAF is what is lost there. Okay, lumbricals are kind of a different branch. Okay. All right, for ulnar nerve, so ulnar nerve comes down into the forearm on the medial aspect. If I were to damage higher up at the medial epicondyle, as we described before at the elbow, then I can lose everything that the ulnar nerve does, including motor at the forearm, which allows for medial flexion of your wrist. If that's lost, then you can't do that. They also call this wrist adduction, because it kind of does medial adduction of your wrist. In addition, I'm going to lose all the intrinsic hand muscles of the hand, except for my loafs, which were controlled from median nerve. And I'm also going to lose its sensory found in this distribution here, as you can see, and on the back side here. And so what happens is, since I lose all my intrinsic hand muscles, I can test it with a few things, such as your Froment's test, which puts a little piece of paper right in here and tells you to squeeze between your thumb and your index finger on the side, squeeze it together, and then you yank it out between them. And if their fingers flex instead to try to grab onto it, that means their ulnar nerve has been damaged. In addition, the person's going to be trouble having to put their fingers together next to one another. And that is going to, like this way, which is adduction of your fingers. Bring your fingers all together like this direction. And so the sensory loss is important as describing as to how far down you are, but the motor is most important as far as how high up you are. If you lose the wrist part of your ulnar nerve, then you're higher up at the elbow. If you just lose the intrinsic hand muscles, then you're at the wrist. And if you're at the wrist damaging the ulnar nerve, you have to know where that is, and that's called Guillaume's canal. And Guillaume's canal, instead of the carpal tunnel, we have this Guillaume's canal as a specific area that our ulnar artery and our ulnar nerve kind of can travel through. And so that's kind of damage. You can feel your ulnar artery pulsating on the other side of your forearm rather than your radial. Okay, so now on to your radial nerve. So your radial nerve is important for a few things. It's for extension of your forearm. It's for extension of your wrist. And it does sensory on the back of your hand in this distribution right here. So again, motor, and then ends with our sensory fibers all the way at the end. And that's going to be your superficial branch of your radial nerve, and you can see that right there. It does sensory all the way on the back side of your arm and all the way back side of your forearm as well, but as far as the furthest outreach is, the furthest it can reach is going to be sensory at the back of your hand right here. So the dorsal surface there. I already talked about our anatomical snuffbox, which is this thing right here, and that has the floor of the scaphoid, and then it has the radial artery and a radial nerve that runs right through here, but it's just the sensory branch of our radial nerve. And so if I damage all the way up at the mid shaft of the arm, remember mid shaft damaged R of radial, then this person cannot extend their forearm, they cannot extend their wrist, and they cannot have sensory on the back of their arm, their forearm, and the back of their hand right here, the lateral aspect of the back of the hand over the thumb and second and third digits. And then if you damage it lower, so such as at the elbow, then you can extend the forearm, but you cannot extend the wrist, so you're going to have this kind of wrist drop. And then instead of saying wrist drop, they never say this, they always say decreased grip strength. So decreased grip strength, and you might be like, what are you talking about? Grip strength comes from your flexion of all your fingers. Well, how about this? Flex your wrist as far as you can, 90 degrees. Flex it as far as you can, and now try to grab on something, like grab onto your hands and squeeze as hard as you can. I bet you probably barely can feel it on your finger. You're like, no grip. But if you straighten your wrist as if you're about to do a pull-up on your finger and squeeze, you can have all your might in there. So it's important for not only just the flexors to be able to squeeze all your fingers, but you also have to have your extensors over here to balance it out so you can get the maximum force of squeeze in your hands. If it just goes like this and if flexing, you have like very little strength to be able to grab anything. And that's why they call it decreased grip strength. And then if it's at the wrist specifically, then there's no muscles that are affected, because what did we have only here is going to be sensory. And so you only have sensory over the dorsum of the hand is lost. Okay, so now an important anatomical structure and structures that pass through the wrist, and it is very clinically relevant as well. And that is carpal tunnel. And so you might get questions on your boards that say, what are the things that pass through the carpal tunnel? What is the nerve that passes through the carpal tunnel? What is the distribution of pain because of that nerve passing through a tight carpal tunnel? But as far as for right now for anatomy, you can be asked all of them. But for your BSCEs in step 1, you should just know the general concepts that there's flexor tendons that run through here. There's a whole bunch of them. There's the median nerve, which gives you all the sensory involvement and pain that this person has with carpal tunnel. And then other things are how can we fix or treat this patient in this area. And that's pretty much all you need to know as far as carpal tunnel syndrome, all the way up through year 4 of medical school, actually. You're not going to be a hand surgeon at the end of 4th year. You can after your residency, but for right now, that's all you really need to know at this point. So carpal tunnel contains a lot of things. Most importantly, it contains your median nerve. Your median nerve, you can see this located right here, this little yellow guy. And the median nerve is very important, as we talked about, for controlling the muscles of the thumb and the first 2 lumbricals, and then it does the sensory kind of all over this area. So if I have damage to this right here in the carpal tunnel, I'm going to have pain in this sensory dermatome here. I can also have weakness in all those motor areas. And so that's why we don't want to have that happen in patients when they have carpal tunnel syndrome. And that's actually why they have those pains in this particular location. The other things that run through here are all the flexor muscle tendons that go through the wrist to the hand. And that's either for your fingers, for your wrist, or for anywhere else in your hand. If it goes from the forearm into the hand, it goes across through the carpal tunnel if it's on the flexor side. So the first important thing is your flexor retinaculum. So your flexor retinaculum is pretty much just a kind of a basic muscle that runs across this way like this. That's not that important actually, but it does actually go through there. Next is the most important ones, and the ones that give off a lot of fingers are your flexor digitorum superficialis and flexor digitorum profundus. So these, each of them have 4 tendon fibers for digits 2, 3, 4, and 5. And the superficialis only ends right here. But then the profundus, or the deep one, the one that profoundly penetrates through your superficialis, extends up here as well. And so this is going to be your profunda. Profunda goes up to these ones, and then superficialis goes to these ones. And then I will actually show you this on Essentials Anatomy in just a second. And then flexor pollicis longus is one muscle that not everybody has, but it can be passing through here, and that's flexor pollicis longus. And I'm sorry, not everybody has this. Flexor pollicis longus is for flexing of your thumb. And then one other muscle that can kind of run over the carpal tunnel is your palmaris longus, and this one not everybody has. And I will show you actually what this muscle is, so I can get you a nice free point on your BSc 1 and BSc 2 when it comes that time. So let's switch over to Essentials Anatomy and I can show you. Okay, so here we are with Essentials Anatomy, and I want to kind of show you this nice, wonderful application, how it works, and some things that you can kind of really help strengthen your anatomy as far as what structures you're kind of learning in different areas. And so we're focusing here on the kind of forearm to wrist and fingers. So I kind of want to show you some of the cool things that this application can help you learn. And so this wonderful little funky looking palm-shaped muscle is your palmaris longus. So this is the one that I was pointing out just in this last slide that not everybody has. This is kind of a useless muscle. It helps a little bit of contraction, but not everybody has it. It's not that important. So this is a muscle that if someone comes in, a 45-year-old man with degenerative joint disease, and he has a very painful right knee problem, and he has his knee is kind of locking, and he cannot extend his knee, and so he's having some problems with it. And we go in and do an MRI of his knee, and we see that his muscle attachment of his extensor muscles, such as his quadratus femoris, the muscle that extends the knee, down here, this one right here, rectus femoris, this muscle is not, its tendon has been ruptured. And so we look around on the bottom and we go, oh, where do we find some tendon tissue that I can reattach this muscle with? Well, remember, there's only one muscle that is entirely useless in the body that we can kind of cut out and use for nice tendon tissue, muscle tissue, and things like that, and that's this muscle. So a clinical scenario of someone that has surgery and they run out of tendon, where can I go to get some extra tendon material that's growing in this patient's body? It's the palmaris longus. Same concept applies for when someone has a coronary artery bypass disease, when they have atherosclerosis in their coronary arteries of their heart, so cardiovascular disease. Someone has bypass surgery or open heart surgery, right? Sometimes the vessels are occluded, so we need vessels from somewhere else. And where can we go for vessels? Well, we like to go for our radial artery, which runs right here. So we can cut out the radial artery and stick that over into our heart as a bypassed graft, so allow the blood to get back to the heart. And that's two concepts that you can apply anatomically for treatment of pathology. Damaged tendon, need tendon tissue, use your palmaris longus. Damaged artery somewhere and you need artery bypass graft, use your radial artery over here. And they're both in the forearm, which is nice. So if I remove this palmaris longus, you can see some of the other tendons that are running through this. So this is your carpal tunnel right here. And we have our flexor retinaculum is found across here, but don't worry about it, I took that off. And then we have some of our tendons that run through here. So we have our flexor digitorum superficialis, and you can see where this kind of extends. So let me zoom in so you can see a nice sharp picture of where this superficialis actually binds to. So this is that part of the finger that I was showing you guys, that it only extends to that middle phalanx here. It actually doesn't extend to the distal phalanx. And so that's why we call it the superficialis, where profundus is the one you can see piercing and going profoundly deep within and breaking through your superficialis to reach the end of your fingers. And so this is a nice clinical vignette of someone that comes in and they have problems with flexing your fingers. And you notice that this patient has problems bending the very tip, or the distal phalanx cannot flex, but the rest of the finger can flex. The distal phalanx, the very end, the tip of the finger cannot flex, but the rest of the finger can. That is telling me that the profundus is the one that has been damaged. Something happened to those tendons that lost that aspect. Now that is actually quite high yield for this upper limb. And so those are our flexor digitorum superficialis, flexor digitorum profundus, and then we have one more flexor that runs through here, and that's going to be your flexor pollicis longus, and that's this muscle right here. We have things that run under the carpal tunnel, and those are our flexor carpi radialis and flexor carpi ulnaris over here. Those are controlled deeply in the forearm by your radial, from your median nerve and from your ulnar nerve over here. But they are not in the carpal tunnel, they're below it or deep to it. And then we have just the flexor pollicis longus left. And that extends all the way to the edge of the thumb, allows for flexion from the forearm of your thumb. So now, what happens if this person has carpal tunnel syndrome? Well, if I have a narrowing of this canal, I have this transverse carpal ligament that's compressing the nerve's going to have pain, and it's going to have pain only in the areas that it does sensory. So these first 3.5 digits here on the palmar surface. And that's going to radiate whenever you push on this, you tap on that, you have them hyper flex their wrist. Anything that's going to compress this nerve is going to cause this pain to be elicited. And that's carpal tunnel syndrome. And the nerve that's involved is your median nerve. And yeah, that's pretty much carpal tunnel syndrome. But other carpal pathologies come down to broken bones. And broken bones, what I mean by that are very, very, very small broken bones. And the bones of the carpal bones have their own little kind of mnemonic. And the mnemonic for that is some lovers try positions that they can't handle. And the way that we remember this is starting towards the thumb. So you can see that you have this nice scaphoid bone over here. And the scaphoid has your trapezium, and then you have your thumb over here. Okay, this is your thumb. Okay, your first metacarpal is thumb, and that hooks up to your trapezium and scaphoid here. And you start on the first layer more proximal, and you go across, and then you start on the second layer more distal, and go across as well for this mnemonic to work. So sum is scaphoid, lovers, lunate, tri for triquetrum, positions for pisiform, and then we start a second layer. Positions, that is trapezium, they trapezoid, can't, capitate, and hamate, or handle hamate. And so these are the carpal bones here, and the two that you really should know are the three that you should really know is the hook of hamate bone. I'll show you that bone in just a second. The scaphoid bone for most likely fractured, and so if you have a common fracture of your carpal bone, it's your scaphoid bone. Why is there a problem with this? Because you have proximal avascular necrosis. So I have to describe this to you now. So the blood supply from your radial artery comes in and supplies your carpal bones and your hand. Okay, it makes a nice little loop like this and meets up with your ulnar artery that comes in here. Okay, so your radial artery and your ulnar artery make this like palmar branch, and then it gives off branches to each of the fingers that come out here. Okay, however, it also gives off blood supply to your scaphoid, but it comes in this way. It comes down and comes proximal. So if I have fracture through it, what's the part that's not going to get blood supply? Is the more proximal portion. Why? Because you have this retrograde blood supply to the scaphoid bone. So proximal avascular necrosis can occur with a scaphoid. Again, if this occurs, you have a fracture of this, where does it hurt? Anatomical Snuffbox. If you poke on that and it hurts, that's what we're talking about. If you have a dislocation, okay, if you look at your wrist and you hyperextend your wrist and you feel a bone sticking out near where your radius goes into, that is your lunate. So imagine you falling and tripping and falling and landing on your wrists. Well, that bone that's sitting right there is going to be your lunate. So it's the most commonly dislocated bone is your lunate, and that's right at the bottom here. And so those are kind of the pathologies. I'm going to show you the hook of hamate and why this is important. So here we are with essentials anatomy back real quick. And so the nerves of the hand, we talked about our median nerve, which comes down here. And we also have our ulnar nerve that kind of runs down here. And so our median nerve goes through the carpal tunnel. The ulnar nerve goes through Guillen's canal. And the ulnar nerve innervates a lot of things within the hand. However, there's a couple bones or a couple pieces that we want to be careful of damaging or hurting, because I can kind of snap off this nerve, the ulnar nerve, because of its its location in association to these. And so one is your hook of hamate. So you can see this hook right here, right under the nerve. So if I land on my hand really hard, this hook of hamate can snap my ulnar nerve in half. In addition, if I have a dislocation of my pisiform, this guy right here, this little ball, if this dislocates, I can damage this nerve right here as well. So those are two kind of considerations for if someone has ulnar nerve at the wrist damage, it's probably due to the hook of hamate or due to your pisiform dislocation. Okay, so now let's talk about some of our wrist fractures. Now one of the, this is actually one of my favorite things, and this is why I'm showing this video from Key and Peele, but our wrist fractures, there's two that you should know that are important. And one is our Colles fracture and one is our Smith's fracture. And so our Colles fracture, so pretty much what we're doing is we're fracturing the radius at the distal forearm. And radius at the distal forearm, and this fractures, we have a distal segment and we have our proximal radius segment right here. And when we describe their location to one another is where we get the difference between our Colles and Smith's fracture. And so our Colles fracture is where I smack someone in the face. So I have someone's face right here. Or maybe they're actually sad because I just smacked them in the face. And they're a little crying. Aw. So this is, that's a really horrible picture. But okay, this guy, if I smack him and it fractures across this, my hand is going to go actually backward as the rest of my arm continues this way. And so if the distal segment is actually posterior, if that distal segment travels posterior, this is called a Colles fracture. And this is why I'm showing Batman here smacking Robin. As you can see, that this is the way that he's just smacked this guy here. If the distal fragment goes posteriorly, that's a Colles fracture. This picture actually is my best friend's arm. Jake, courtesy of him, allowed me to put this into my YouTube video. He was driving a quad in the sand dunes down in SoCal and landed on the handlebars a little bit too hard and got a little Colles fracture right there. So you can see that posterior dislocation of the distal segment. And then we have our Smith's fracture, which is the other way. And so when this distal fragment actually moves anteriorly, such as when you're backhanding someone over here, so this is someone that's very sad and you backhanded them, then you can remember that Smith's a pimp. And so here they are, Key and Peele. They're doing this forehand, backhand game. If you've ever seen this Key and Peele, if you haven't, it's hilarious. It's really funny. But this guy's getting backhanded severely from this guy, and so he could probably get a Smith's pin fracture and have that distal segment move forward. So, pimp hand, right? All right, so next is our tendon sheaths. This isn't that important. I'm just going to describe this really quickly. In your hand and your forearm, you have tendon sheaths that wrap around the tendons. That's why we call them tendon sheaths. And each of these guys are located in kind of different places. Some are separated away from each other. And why this becomes important is if there's an infection that occurs in some of these digits. And so the way they actually orient these questions is someone has an infection of their thumb, and can it travel into the forearm? Yes, absolutely it can. Why? Is because this sheath continues down and goes into the forearm. So if someone has cellulitis of their thumb, the infection can spread because the tendon sheath continues down into the forearm around your thumb. But the tendon sheaths of digit 2 through 4 are ones that their tendon sheath ends in the finger. So if I have an infected second, third, or fourth digit, that infection cannot spread beyond this fascial sheath or the tendon sheath because it stays within here. It kind of just stays in the local finger area. But the pinky, on the other hand, the pinky is associated and hooked with the more proximal portion of all these, and it can continue down into the forearm. And so if you have a pinky infection, then that is not so fancy, and it's able to make its way down into the forearm there. Okay, next is some of our deformities that occur with rheumatoid arthritis. This is not super high yield. It's just some finding that you find with rheumatoid arthritis. But these are called your boutonniere deformity and swan neck deformity. And it's just describing kind of the flexion or extension of each of these digits. So if you can just think of a swan, and that's the first one you think of. I mean, obviously, what is a swan's neck doing? Well, the distal one is where the head is. So you can see its eyes right here and its bill, right? So here's the wonderful goose or swan. And so you'll have a hyperextension or a hyperflexion of the distal interphalangeal joint, so DIP, and a hyperextension of your PIP, or proximal interphalangeal joint. So hyperflexion of your dip, hyperextension of your PIP, that's swan neck deformity. Boutonniere's deformity is the opposite. So this is hyperextension of your DIP, and this is hyperflexion of your PIP. And those are just the difference between those. Why this is caused? Well, rheumatoid arthritis is a chronic inflammatory autoimmune disease of your joints, and that causes all these destructions of the joints, and the joints start getting all deformed and moving in different directions, and you can get either one of them.
MedSchoolTutors!
You're at SGU, and you're thinking about Step 1. There are so many resources and so many opinions. How do you know which path to take? You've worked so hard, and you deserve to match into the specialty of your dreams. MedSchoolTutors has helped nearly 1,000 SGU students get their best scores on their CBSE and USMLEs through highly personalized one-on-one tutoring and individualized advice. Our SGU students see average Step 1 score increases of over 30 points when working with us. Scores that are their tickets to competitive residency spots around the country. Schedule your free phone consult today to be matched with your tutor. MedSchoolTutors. Get where you want to go.
All right, so that pretty much clears up all of upper limb anatomy as far as basics anatomy, all your clinical anatomy. I gave you some vignettes kind of to break down how they ask questions of each of those. And pretty much as far as your anatomy course, do those Gray's Anatomy practice questions. This should definitely help you through all those. And you should be quite solid for your anatomy exam. And you should also be quite solid for your BSE 1 to CBSE, NBME practice exams, your UWorld come designated study time for your Step 1 and your Step 1 when it comes to anatomy. I try to point out all the high yield things, show you the images, show you the basic structures, in addition, all your clinical presentations that come into play. You're going to have multiple times that you're going to be able to review this material, but this should totally now start to make sense for you. All right. Thanks for watching. Don't forget to subscribe. Check out our Facebook page. You can get this PowerPoint and follow along. All right. Happy studying.